increase intracranial pressure, you see a rising blood pressure, but you see a widening pulse pressure, meaning systolic gets higher, diastolic gets lower. Pulse rate decreases, respiratory rate decreases, and it gets all funky with those Cheyne-Stokes respiration. Okay? What else? Head of the bed at 30 degrees as a general rule. Okay? Some docs will like it flat, but most of the neurosurgeons that I've worked with the exception of people after shunt placement, okay, they will put the head of the bed up 30 degrees. Okay? And because it helps to drain the blood from the head, it helps to shunt CSF, and it increases cerebral blood flow. Okay, what else do we learn?
The head should be in a natural midline position.
Midline position. No crooks, no crannies, nothing like that. We want to make sure that that head's midline. Even when they're on their side, it needs to be straight. They're scrunching the pillow up. Getting in that position. Okay, what else? Cushing's triad. Basically, we talked about that. What was your?
That the level of consciousness is the most sensitive indicator.
Say that again.
The level of consciousness is the most sensitive thing that we look at.
Okay, and say it one more time.
Yeah, level of consciousness is the most sensitive indicator of neurostatus.
Okay. You get it?
Yeah.
Okay, good. All right. So let's go on from there. Basically, one of the things we talked about yesterday is maintain fluid and electrolyte balance. Remember, we talked about sodium being one of the things that can contribute to cerebral edema, either very low sodiums or very high sodiums. And basically what you will see is that to the point that the brain will swell so much it will cause seizures. Okay? This is one of those rules. Basically, neuro patients only get either normal saline, half normal saline, or quarter normal saline. Okay? Do not hang D5W on any of these patients. D5W contributes to cerebral edema because what it does is it goes into the cells and causes that leaky cell syndrome, that vasogenic edema. So normal saline is a fluid of choice. And they may change it to quarter normal or half normal depending on what the sodium level is. Or no normal. One of the things we want to do is to keep these patients normobulimic. Okay? We do not want them dehydrated. We do not want them to be overhydrated. So that what you will see is they want them to maintain a normal volume. Now, as a general rule, for an adult, you're going to see it run at about 75 to 100 an hour. Okay? And that will maintain that normobulimic state. How can I tell if that patient is normobulimic or not?
You're out for 30 hours.
Yes, ma'am. What else?
Most get dinner.
Yes, ma'am. What else?
Edema.
Correct. What else? Somebody else help her out. Weight? Yeah, but I got to move everything off the bed if you will wait.
Mucous membranes.
Mucous membranes, that's a good test. But what else? Hoarse basically means they're dehydrated. Okay?
Are they awake to tell us?
No. What do you do depending on their condition, every
Vital
hour,
signs.
every 2 hours, every 4 hours?
Vital signs.
Vital signs. Okay? People with normobulimia will have a stable blood pressure and they will have a stable pulse rate. Okay? I will tell you, pulse rate will elevate before your blood pressure drops whenever you have a patient that's experiencing a loss of fluid or a loss of blood. Okay? It's going to be one of the first indicators is you're going to see an elevating pulse. That's, of course, if Cushing's triad has a big deal. Now, this is one of the guidelines that physicians use for treatment of patients with elevated ICP. Level 1, basically that is not bad. Okay, they may have some small spikes of ICP elevation and some small plateaus, but clinically it's not that significant. What they're going to do is, this is basic nursing care if you look at it. Pain and sedation medications. Maintain normothermia, patient positioning with head of bed elevation and midline neck alignment. Okay? Pain will elevate ICP. Agitation will elevate ICP. So we need to chill them out a little bit. No chillax and watch Netflix though, but just chill them out a little bit. That's what we're going to do to maintain that ICP. Level 2, meaning that they're showing some clinically significant signs. They're starting to have some elevation of ICP, you think, but you really don't know until you put that external ventricular drainage system in. Okay? Now, you may do hyperosmolar therapy. Well, we'll talk about that a little bit later, but basically that's osmotrol or mannitol. It's an osmotic diuretic that we use. Mechanical ventilation is a problem that you may see. But what we want to do is to maintain that oxygen greater than 60 and that PaCO2 of 35 to 40. What's normal PaCO2?
35 to 45.
35 to 45. So I want it in that low normal range, right? Okay? Carbon dioxide is a very potent vasodilator. Very potent. Hypoxia is also a very potent vasodilator. And when you vasodilate the vessels in the brain, what it does is it brings more blood into there and therefore increases ICP. So we want to keep them as near normal levels as we can. Okay? If these interventions don't work, then they may do what we call neuromuscular blockade. This is where we knock them out. Barbacoma. Usually a little pentobarbital, a little fentanyl, and a little Versed. You can't fix stupid, but you sure can sedate it. Okay? Basically, what you're going to do here is induce a coma. Because what does that do? It lowers that metabolic rate. And it decreases the ICP because the oxygen and glucose requirements are not as high. So you don't need as much blood shunting to the brain at that point. Okay. Mild hyperventilation, mild meaning that we probably want that CO2 closer to that 35 than the 40. And then mild hypothermia. Put them on a cooling blanket. Drop their temperature 3 to 4 degrees. For barcoma and decompression craniotomy. Basically, these are the decompressive craniotomy is where they would take a bone flap out to allow that brain to expand so that that brain is not a closed box. Now, that decompressive craniotomy would only be done in someone after the sutures have closed. So would I do that in an infant? No. Sutures haven't closed. So what you often will see is expansion of their head. And that is okay for short periods of time. But with adults, we may have to take a bone flap out. And that brings a whole other set of nursing problems, because what you've got is when you touch the skin, right underneath it is the brain. So what do you think your nursing care is going to be like to protect that brain? Infection control. Skin is usually pretty much closed. Keeping them from hitting their head, definitely. But what else? Am I going to allow them to lay on that side? No. No. So those are some of the things you have to think about. And I'll show you some pictures in just a minute. I also like a lot of pictures. All right, so we're going to monitor our ABGs, looking specifically at that oxygenation level and CO2. Remember, it does not do you any good to look at that ABG and interpret it and then not do anything about it. Okay? If you notice that their oxygen level is low, then you contact your respiratory therapist and say, hey, do we need to bump up on this oxygen that we're giving them? Or if your CO2 is still up, okay, one of the reasons we retain CO2 is we're not breathing and exhaling it, okay? So we want them to breathe deeper and faster. So if they're on a ventilator, a mechanical ventilator, then what we're going to truly do is increase their rate of breaths to blow off more of that CO2. Make sure whenever you interpret these things, you do something about it. Osmolality. One of the things that you will see is that we want these folks to have a serum osmolality of about 310 to 325. Normal level is 280 to 300. 325. What that will do is just that simple process of perfusion. If I have a higher osmolality in my vascular space, then it's going to draw fluid from the extra and intracellular space into the vascular space. So what we want is that constant removal of that edema in the brain. And you do that by keeping their osmolality a little high. Usually serum, it is a better indicator. Number one, because they may have bad kidneys and it will be altered that way. But blood usually is pretty fair on the mark. Okay. So you could do serum, they had fairly decent kidneys, and you wanted like a test in between. Okay. But usually we do blood. Again, head in that neutral position. Intracranial pressure monitoring basically is one of the things that we're going to do. We're actually going to put a catheter in this person's brain, into their ventricle, and measure what their pressure is. And if it gets too high, then we're going to drain some fluid off. Okay? We want these people kept sort of quiet and easy. This is not the people that need 10 family members sitting in attendance at all times. 1 or 2 at the most would be the limit that I want. And I wouldn't want a lot of ruckus going on. Again, we're going to treat that cause. If it's a stroke, then what we want to try to do is to eliminate the source of the blockage or decrease the bleeding. Same thing with traumatic brain injury. CT or MRI is going to be diagnostic of choice. Again, CT, quick, easy, can do it 15 minutes, and you can tell if there's blood in the head or not. You also can see what the skull fracture looks like, or if it was a penetrating injury like a gunshot wound or a knife wound, what specific area of that brain is going to be impacted. Coolest x-ray I ever in my life seen. This guy walks into the emergency department, with a 10-inch butcher knife up to the hilt in the top of his skull. And of course, somebody had to ask, well, what happened? Well, my girlfriend got mad at me. She took that butcher knife and went, whoop. And I'm thinking, what does this woman look like? And whenever we finally saw, she did come in to see him. She was about 6'3", probably 270. I mean, big woman. And it basically, the knife went straight down the corpus callosum with very minimal damage. But you see the x-ray, all you see is that knife transecting his corpus callosum with the rest of it sticking out. It was also, once we got to listening and talking to this man, we called Adult Protective Services because he'd also done some type of indiscretion that she didn't like, and she poured boiling water on his junk and gave him 2nd and 3rd degree burns about 3 years ago. Well, he wanted to go back and live with this woman, and we said, no way. I mean, the 3rd time is not the charm. I don't know. He wouldn't press charges. The man would not press charges, so the DA finally. Yeah, the state finally pressed charges because it's too intense. But it was the coolest x-ray I've ever seen. All right, so pulmonary ventilation, mechanical ventilator is often indicated because that way you can maintain their oxygen level, their CO2 level. IV fluids, we're going to use what? Saline. We're going to put a Foley catheter and have strict INO on these people. Strict INO. We want to know what their fluid status is at all times. Now, one of the things that you will see is that if they do what we call a decompressive craniotomy, they go in and do what we call burr holes, B-U-R-R. What that is they do 4 or 5 little and then sometimes they will put a bone saw, which is like a wire, and then they will saw it off and then just pull the flap off. Okay? Now, that bone can be frozen and then put back later. But burr holes are done with a little drill. It's really sort of cool because what it does is it senses when there's no force against it and it'll stop drilling so that you don't go down into the brain. Okay? Basically what you see here is this is the brain itself, and you can see all of the arteries and veins, and the bone flap basically is just laid to the side. Okay? It's really much cooler if you look at it on your yeah. So, and you can see here, there's all gyri and sulci here, but look how smooth this area is right here. This is where your pressure is. Okay? Now, with interventricular catheters, there's 3 or 4 types. They will do an epidural bolt or subarachnoid bolts. Bolts basically go into the epidural. The epidural goes into the epidural space. The subarachnoid goes into the subarachnoid space. But all they do is measure pressure. You cannot drain from them. Okay? So typically what you will see them use is this interventricular catheter. It goes into the ventricle, and not only will it measure pressure, but you have the option of draining CSF to decrease the pressure. So it can be both a diagnostic tool as well as a therapeutic tool. Now, nursing care associated with that can be very tricky. Okay, it depends on where they put it in. Sometimes they will take them to the OR to put them in. Sometimes they do them in the intensive care unit. It is a sterile procedure, very similar to what you would see done in the OR, because you don't want to introduce any germs into that brain. Okay? So one of the things that I would have to do in setting this up is to make sure that my set, when I got it out of the box, was complete, that I primed the tubing with preservative-free saline, okay? Preservative-free. The brain does not like preservatives. It will cause irritation and can cause seizures. That's why anything that is injected into the neurological system, either brain or spinal cord, has to be preservative-free. Okay?
Which one did you draw out?
The interventricular catheter. Because what it does is it goes into the ventricle. All right. Now, one of the things that you will see is that, no, I just didn't need you to know the anatomy of an ear, but I want you to know that the tragus, that little point right here that a lot of people pierce that looks like it hurts like the bejeebers, it does. That is your anatomical landmark that you're going to zero your interventricular catheter drainage system to. The tragus of the ear is at the level of the foramen of Monroe, and that's the anatomical landmark that we use. Foramen of Monroe, M-U-N-R-O. So what you see is that often these systems will either come with a level or they come with a laser level, so that my stopcock and my drainage system is equal to that here. Okay? That's my zero level. Because I want to be able to measure what it is at this specific level. Now, if I elevate or lower this chamber, that is going to alter my drainage. Okay? It's just like if you have an IV bag that you're trying to prime the tubing on. Okay? What do you do when you want it to run fast? Elevate it. When you want it to slow down, if you bring it down, it'll slow down, right? Okay? Same principle. If I elevate this, actually my drainage is going to decrease, because what happens is that intracranial pressure has to overcome this pressure to drift. However, if it's low, it's a much less lower pressure. Okay? Usually what you will see is this drip chamber is either, you will have a specific order, 10 to 20 centimeters above your stopcock. 20 is usually what you will see. Because what the doctors want to do, if they leave it open to drainage, is that when that ICP hits 20, it's going to drip. Drip, drip. Now, one of the things you have to remember is that you can't drain and measure ICP at the same time. So what you've got to do is, if you're monitoring ICP, if there's a transducer set, the whole 9 yards. I'm not teaching y'all how to do this, I just want you to know the principle. But what you will see is that if you notice that the ICP has gotten up and has stayed up, typically you will have an order to drain 5 drops or 10 drops or something like that. So if you open your stopcock to drain and count your drops, you can close it back and see what your ICP has done. Okay? Now, one of the things that we often do whenever we get this set up and at the right level, typically I have another nurse check it to make sure that I've done it appropriately, is I unplug the bed. I don't want x-ray coming in, sitting him up to do his chest x-ray, and then laying them down. Okay? And often I will put a sign over the plug for the bed that says, do not reattach unless you talk to the nurse. Family members need to know that they cannot reposition that patient without the nurse present. Because anytime they elevate the head of the bed or lower the head of the bed, it changes what your leveling is. And you need to know that so you can re-level. Okay? So if I have got this set and someone lowers my head of the bed, it has to overcome a higher pressure in order to drain. Okay? If I've got it set up like this, and someone elevates the head of the bed, it's going to drain freely. And what can happen is that if you drain off too much CSF, the brain will sink in the cranial vault, and you may tear bridging veins. Okay? So you can have a bleed from it. So we don't want to drain it too quickly. That's why you only get an order for 5 drops or 10 drops. Okay, usually it's about a mil that you're taking out. Okay? The other thing is that we want to make sure, this is a little 2-year-old with a interventricular catheter, is like Julia said, we have to make sure that this is kept sterile, or somebody said it, because we don't want infection. This goes directly into the ventricle of the brain. So any dressing change, any change of that equipment is done under sterile conditions. Mask and gloves, the whole 9 yards. Okay? Typically, these dressings are changed every 2 to 3 days. You look for signs of infection. This interventricular catheter normally stays in for about 5 to 10 days. And then they can move it to the other side if they need to, if they still need to monitor.
How long does it stay?
5 to 10. 5 to 10 days. Or take it out.
Who actually puts those in? Like the doctor?
It will be either a doctor or it can be nurse practitioner or physician assistant. Depends on your hospital policy.
And if they're like comatose, is that whenever they would do it at bedside, or they even whenever they're like awake?
How do you give somebody a little Versed and it don't matter? Don't matter. I mean, I've done these in emergency situations where we didn't have the burr drill, and it's a twist drill. You set up a little set, it's a little drill, you hold their head like this and do this and pop that bad boy in. I mean, you can do it in 10 or 15 minutes and the doctor knows what he's doing. But it's one of those things that it's better to be done under sterile conditions. Most people take them to the OR now, but they can be done at bedside. Now, who changes the dressing will depend on your hospital's policy. Okay? Some, it can be the nurse. Some, it can be nurse practitioner. I know at Duke now, it's really interesting. They've got a 16-bed neuro ICU, and they've got a nurse practitioner that works 8 beds on either side. They staff that unit with a nurse practitioner 24/7, so that if there are things that come up, you've got a healthcare provider right there on the unit, and you don't have to worry about calling someone. And that's one of the things that we're starting to see more and more in your intensive care units, is that not only do you have physicians that are on call, but you may have a nurse practitioner that stays on the unit to handle daily, everyday problems. Which is nice because if you need orders, they're right here. All right, so let's talk about some medications. Osmotic diuretics, probably mannitol or osmotrol is going to be your drug of choice. Any of you ever given it? Okay. It comes as a vial. It's a big fat vial. And typically what you're going to see is it's liquid, but a lot of times it will crystallize. And so what you have to do, if you see that there are crystals in it, you don't want to infuse it like that. You sit in a tub of hot water and the crystals will disappear. You still deliver it through a filter because of the microcrystals that can really form. Typically what you will see, I think your book says to give it continuously, but I've never seen it done like that. Typically we do it every 6 hours or so. And a lot of times you may see it Q6, PRN, elevation of ICP. If you are giving it, then definitely you're going to check that serum osmolality, because what you want to do is have it in that therapeutic range. Okay? basically what mannitol does is it sucks that vasogenic edema out of the brain and dumps it into the intravascular space. Sometimes at that point you may touch them with a little furosemide or Lasix to get them to pull it off. Okay? Now urea and glucose can do the same thing as mannitol, because mannitol is basically sugar alcohol. Okay? But I don't see these used as often. You see mannitol used much, much more. The loops, those are like your furosemide or Lasix. Okay? Glucocorticoids, like steroids, will depend on your reason for increased intracranial pressure. Used to be that everybody got steroids, like Oprah. You get a steroid, you get a steroid, you get a steroid. Not anymore, because what we have found is that they really don't help that much in some patients, and they really make the situation worse in most because of the elevation of glucose. The exception to that is going to be people with brain tumors, because people with tumors often will have an area surrounding the tumor that has very large amounts of edema in it because of inflammation. And the steroids will decrease that inflammation around the brain tumor. So typically, you will only see glucocorticoids or steroids used with people with brain tumors. Anticonvulsants. Used to be we gave everybody, well, you might see, so we're going to give you Dilantin and Beamer. Not anymore. Typically what you're going to see is that they will wait to see if they have seizure activity, and at that point they treat. So they may or may not be on anticonvulsants. If they seized at the time of whatever injury it was, then yes, they're going to get anticonvulsants. Paralytic agents. Like I said, a lot of times what we do is paralyze these people to keep them from moving, to keep them from being agitated. Like with pancuronium bromide or Pavulon, okay, or something like that. That's a paralytic, meaning you can't move any of your muscles. But please, people, be aware that does not change their level of consciousness. They just can't move. I can't imagine anything worse than laying there being paralyzed, not able to move, and I know what's going on around me, and I can feel pain. So, if you give these people paralytic agents, they need to get a sedative, and they need to get pain medication, usually fentanyl, or propofol, or Versed, something so that they don't remember what's going on. Just because they're paralyzed doesn't mean that they can't feel pain. Yes? It's one of the most horrible things that I can imagine. Oh, I can't say that I blame him. Can't say that I blame him. Yeah, I'm one of these people. I don't like anything in my throat. I mean, nothing. God help me if I ever have to have an MG2. I think I'll just go ahead and die. But I extubated myself in the OR. I just don't like things with. So it's one of those things that the anesthesiologist, I give them permission to tie my hands down anytime time I have to have surgery because I don't want to extubate myself again because that was not fun. Because the cuff was up, oh my heart. I can hear it. Next time, give me more anesthesia. All right, antipyretics. Your ibuprofens, your acetaminophen, making sure that they're kept normothermic. Maybe even having to use a cooling blanket to make sure that they're kept in that normal temperature. What are some of the other measurements that we're going to do? Just plain old nursing care. Cut down on stimulation. Don't cluster care. And we're going to watch. I mean, you know, if you have a patient that every time you give them a bath, their ICP goes up to 20 and it stays up, don't give them a bath. However, if you give them a bath and their ICP goes down, then they might get more baths every day. Especially if you massage their feet or whatever. Okay, so look at what the impact of your nursing care is. You may have to be the Brunhilde that says, I'm sorry, but you can't come in here right now. He's having elevation of ICP, and I need no visitors in order for him to calm down. However, be aware that this family is in crisis mode right now. Because if you've got someone with this elevated ICP and they got drains and tubes and ventilators and everything going on, think of the stress that they've got. Their ICP is probably also up, okay? But you have to explain to them, this is why I'm not allowing you to visit right now. When the ICP comes back down, I'll be glad to come out and get you. But I need to make sure that we can keep that brain as calm as possible in order to keep having you. Okay? All right. So, how many more slides?